So today I'm going to talk about the incidence and predictors of COVID-19 infection in prison healthcare workers. Before I start, I can't advance the slides. Sorry. Okay, before I start, I just wanted to acknowledge our contributors as well as thank the ERC for funding this project. So as we know, since the onset of the pandemic in March 2020 till current, there have been at least 99 million cases within the United States and over 1.1 million deaths. And during the first few months of the pandemic, many United States health systems were unprepared to curb the spread of the then emerging pathogen. In the prison system, this may have been amplified due to additional challenges with ventilation, as well as the limited ability of staff and incarcerated persons to practice social distancing. Okay, so I just need some help with advancing the slides. Somehow I'm not able to do that. Okay, so our study aims, they were to assess the predictors of SARS-CoV-2 infection among correctional facility healthcare workers, as well as to provide insight into preventive measures that can be implemented to correctional facilities in future epidemics, as well as to develop a platform for additional research in this unique population. So next slide. Right, so the Rutgers University Correctional Healthcare or UCHC employees, they provide healthcare to New Jersey Department of Corrections, incarcerated persons, residents, and parolees. And this is general healthcare as well as mental health care. For our methods, we analyze existing and employment records for all correctional healthcare workers employed by UCHC between March 15, 2020 to August 31st, 2020. We only included healthcare workers in our study, and these were like physicians, nurses, medical techs, dentists, medical support staff, and other medical personnel as well. We excluded the New Jersey Department of Corrections staff, specifically the corrections officers. Next slide. Right, so we looked at the test results of these employees, and these results we looked at included only the PCR-based SARS-CoV-2 test results obtained from 3 sources. Routine weekly testing, this was from May 5th onwards, as well as internal ad hoc testing through employee health and outside lab or clinical test results that included a lab report with specimen collection between March 15, 2020 and August 31st, 2020. Right, next slide. So for the individual level data, we looked at age, sex, race, and years of employment. And for the facility level data, we looked at resident population type, prison population size, prison security level, listed as the highest level of security custody that they housed, as well as the geographic COVID-19 risk level stratified as high or low risk group as per on August 13, 2020. Next slide. So we analyzed our individual and facility level data by first summarizing the categorical variables using frequencies and percentages. Then we looked at the relationship between facility and or healthcare worker characteristics using logistics regression models, with the primary outcome of ever testing positive for SARS-CoV-2 during our study period. Next slide. So for our results, we included 3,806 test results from 822 employees. 5.7% of them, or 47, had one or more SARS-CoV positive test result. There was no significant variation by individual level characteristics, and job title seropositivity ranged between 0 to 7.7%, with the highest rates noted in patient-facing nurses and other patient-facing workers. Next slide. So for facility characteristics, the majority of cases occurred in persons working in maximum security prison, and they had a seropositivity rate of 7.3%. And in those working with adult men only, their positivity was 6.4%. Of note, in the medium population, size prisons, their seropositivity rate was a bit higher at 8.7%. Next slide. So for our individual regression results, we found that the odds of having a positive result was at least 1.6 times higher for non-white populations compared to white populations. And the odds of having a positive test result for medical care workers and other workers was at least 5 times that of mental health workers. Next slide. For the facility regression results, we saw that those working in medium population prisons had twice the odds of having a positive test result compared to those working in large population prisons. Next slide. So in summary, we found that patient-facing staff had the highest incidence of infection, and the odds of infection appeared to be higher in non-white employees compared to white employees, and the highest rates were in maximum security prisons. And somehow medium security prison workers appeared to have a lower rate of infection. In that case, it was like 0.26 times that of those working in maximum security prisons. So we postulated that increased staffing and close supervision in maximum security prisons may contribute to higher rates of transmission. Next slide. We had a couple study limitations. For example, a study period was early in the pandemic, where the transmission dynamics may have been a bit different throughout the period as the New Jersey Department of Corrections instituted changes, or test results that were not substantiated by a positive lab report were not included, and this may have underestimated our infection rates. And the small numbers of positive results could result in some wide confidence intervals. So we couldn't fully assess some associations. Next slide. So in conclusion, with 4 seconds, correctional health workers, they have unique risk factors for infection with SARS-CoV-2. Administrative measures taken by the Department of Corrections and depopulation efforts may have had a significant role in curbing the spread of infection. And the findings can help focus preventive measures for reducing the spread of COVID-19 in this unique population. Next slide. Thank you.